When you belong to a community, it makes you feel safe. It inspires you to thrive. It honors your achievements, and it makes you feel at home. For nearly 20 years, Belmont Village Senior Living has created communities that have enriched the lives of seniors and their families, providing places where seniors lead healthy, purposeful lives under the care of staff who truly understand their needs. Belmont Village offers assisted living, independent living, and memory care in a continuum that supports residents when care needs change and providing for couples of varying care needs.
It's nice that we can be together. She needs a little bit more care than I do, and I don't have to do any cooking or shopping.
Aging is a gift. We invite you to embrace it with us and be a part of our community and our family. Belmont Village Senior Living, the community built for life.
Good morning. Our guest this morning is Dr. Hossein Samadi. He is a board-certified adult and geriatric psychiatrist. He completed his residency in adult psychiatry and his fellowship in geriatric psychiatry at UCLA. He is currently providing psychiatric consulting around San Diego County, and that includes Belmont Villages, both in Cardiff by the Sea as well as Sabre Springs. And so with that, his research interests are in Alzheimer's disease and late life depression. Welcome, Dr. Samadi.
Thank you very much. Thank you so much for having me here.
Dr. Samari, we thank you for being here today, and we understand you're doing great work at Belmont Village, both in Sabre Springs and Cardiff by the Sea. Take us through your role there and what you're looking to do to the residents that live there.
Yes, well, one of the main joys that I get in life is by treating people that are in difficult situations or situations of hardship. Studies show that almost 50% of people in long-term care communities have some sort of psychiatric illness. And
50%?
50%, that's right. Now, these can be transient, such as what we call adjustment disorder, difficulty adjusting to new living environments, or bereavement, the death of loved ones and various losses. However, some of them have severe and persistent mental illness, such as Alzheimer's disease, which unfortunately, doesn't have an actual cure. So one of the main joys that I get is by working with patients as well as families to identify what the problems are, as well as identify areas of improvement. And I've been fortunate enough to work with various long-term care communities for the last 5 to 6 years. And Belmont Village is one of my favorite ones to go to because they really understand and get what it's like to be struggling both from a patient standpoint as well as a family standpoint with psychiatric illness and disease. So I really love doing what I do there.
Well, so you're going in, you're meeting a person who lives there, and what's the role? I mean, what are you doing in terms of working them through this?
Right. Well, first is the typical medical assessment that I would do with anyone. So I review past history, medications, I review their social history, how they got to the point. And really what I want to try to understand is, their story that makes them unique. It's one thing to sort of group people that live in a particular community as all having the same illness, but in reality, each individual is so unique, especially when they get to be seniors. They've had a lifetime of experience. So what I try to do is just simply understand their medical problem and then understand them as a person, and then try to tailor a treatment plan, if you will, to their particular needs.
So I've unfortunately or fortunately lived this, but I think looking back, there's so many things we could have or should have done differently.
Right.
So when one begins to notice that mom or dad has some cognitive impairment,
Right.
what do they look for? How do they handle it? To try and bring someone in like yourself when mom and dad are still living at home. Right. You may have siblings who don't agree with you. Right. You may have mom and dad who don't want to speak with you. Right. What are your suggestions into getting around all the emotions that are tied in with that?
Right. Now, that's very difficult, what you mentioned. Oftentimes, when you bring in family, you have 5 to 10 different opinions on what to do, let alone what the problem is. So the first thing is to identify, is there a problem and what is it? So to do that, what you try to do is increase dialogue and communication. So try to find out, hey, mom or dad, are there areas in which you're having some struggles? And then ask the people around them, are there areas in which they're struggling with? That could be memory problems, word finding difficulty, or difficulty managing day-to-day activities. And once you identify and understand what the problem is, then it's important to report it. So it's very important not to keep it under the rug and pretend like it'll go away. And oftentimes family members that are in denial do that because it's easier not to admit that mom and dad has a problem.
Yep.
So once you've identified the problem, then you report it. And the most common person to report it to is your primary care physician or trusted medical professional. That could be anyone. That could be the neurologist that sees you, the cardiologist. And once you report it, then that person will have hopefully a system in place to be able to better assess and diagnose the problem and then to guide treatment as necessary.
So would one go to their primary care physician and then be referred to you versus coming to you directly?
Yeah, almost in most cases that would be the case. Let me just step back and say that there aren't many geriatric psychiatrists in San Diego County. I believe there's about 20 for a population of, better than I, a couple million. So there's no way that we as psychiatrists can see every person with memory loss or cognitive issues, let alone late life depression. So we rely upon our primary care physicians to do most of the initial workup and most of the treatment. Very few patients with dementia ultimately see me or a behavioral neurologist.
Why are they not seeing you?
The reason being is maybe they don't need to. You don't always need to see a specialist for every single disease state or problem. Most of the time, primary care physicians can address the run-of-the-mill depressions, anxieties, as well as dementia. Where I get involved is when conventional treatments have not worked, or they really need sort of specialty workup for those rarer cases of dementia or those harder to treat, i.e. those with behavioral problems, wandering, agitation, resistance to care, or with comorbid depression and anxiety that's not properly addressed.
So I'm just going to question in terms of, do you deal with sometimes, let's say the patient's 90 years old,
right,
and the children are in their 60s.
Yes.
Would you treat the children?
Typically
in
I
terms
don't.
of how to deal with all of this?
Oh yeah, as part of my psychoeducation, I do ultimately work with families, 100%. Sometimes the patient themselves are almost non-communicative,
right,
or delirious or altered, in which case almost exclusively I'm working with the resident's family or the staff at the community that they live in. So sometimes there are caregivers and nurses that oftentimes are not the identified patient, but the informant that's responsible for the day-to-day. So I work with not only the patient, but the whole system in which they live.
Now, obviously, every outcome you're looking for a different outcome, but is this a combination of prescription medication and therapy dog, or what are we looking to do?
It depends on the areas of their capacities, right? So if a resident or an older adult is in their early 60s or 70s or even in their 90s, but they're just having some late life anxiety or depression and they're cognitively intact, I'll oftentimes recommend perhaps medications, perhaps psychotherapy, and sometimes both. And by psychotherapy, I'm talking about weekly or bi-monthly sessions with a therapist, and I work hand in hand with very good therapists or psychologists. I typically don't do therapy myself given time constraints, but then what I'll do is I'll work with them to develop an entire behavioral plan, and that'll usually include a combination of medications, therapy, as well as education. Oftentimes issues can be addressed, I find, just by talking to the families and residents about how better to address their needs instead of even doing the more medical model of medications or therapy.
And then you mentioned doing an overview of the medications.
Sure.
I mean, we noticed personally that once we removed a lot of the medications,
Yes.
there was actually better results, because we've gone from, the GP who showed up at your door with his little black bag to everybody going to their specialist,
Right.
and nobody talks to one another, and now you've got medications that have been prescribed by all the different specialists, and until the pharmacist says, oh, there's an interaction with this drug you just brought, this prescription you just brought in. Have you seen that as a major role as well?
Yeah, definitely. You don't know how many times I've gone in, the first thing I say is, oh my God, the patient's on 2 or 3 antidepressants. And guess what? They're still depressed. Or nobody's evaluated the interactions between these medications or the dosing. So very frequently I would say and the problem really is endemic. There are providers with good intention, but they don't communicate. or that everybody figures out, oh, I have the answer, I'll prescribe this. And yes, there are cases in which I've seen where medications themselves, when streamlined or reduced, can improve functioning, cognitive functioning, as well as psychiatric. So one of my main calling points is to minimize psychotropics, and it sounds a little like an anathema that a psychiatrist would want to reduce psychotropics, but I understand medications are not always the answer. Now, at the same time, yeah, medications are not always the answer. At the same time, there are situations in which it could definitely give rise to decreased suffering and allow seniors to live comfortably in their golden years. So there are cases in which I prescribe medications, some in which I withdraw, or some in which you just streamline to sort of say, well, instead of giving 2 doses of a small, 2 medicines at very, very small doses, I'll prescribe 1, but do it with thought about what the patient's symptoms are.
Well, and then the time of day that the prescription's given as well is
Right.
different for everybody.
Yeah.
My mom was a sundowner,
Right.
but not everybody's a sundowner.
Yes. Yeah.
Define sundowner.
Somebody who
I could do that. How about
Yeah,
that?
yeah,
right
yeah,
ahead.
sure.
Go right ahead.
Sundowning is a situation, it's a syndrome where a lot of older adults with various psychiatric conditions will become more confused or sedated or agitated. You don't know what's going to happen around the late afternoon periods. We feel like it's related probably to circadian rhythm cycles and variations within hormone levels. And what just generally happens with a lot of these folks is they just get more pronounced. Whatever their psychiatric symptoms are, they become more pronounced in the late afternoon, early evening period.
So how do you evaluate memory loss? What is the tools to do that?
So one of the ways that I like to do it is first by doing a full history. So you have to understand, like I said, the medical, the social, the family history components to what's going on. Then you try to do some sort of evaluation of their functional abilities. So what we use is things like activities of daily living, which include, toileting, bathing, changing clothes, showering, and then what we call instrumental activities, such as finances, medications, or driving. And that gives us a sense of how are they coping with what's going on. Then specifically for memory issues, I like to use a bedside tool known as the MoCA, Montreal Cognitive Assessment tool. The MoCA was developed in the early 2000s, and it's meant to be a clinical tool, which basically is scored out of 30 points, and it evaluates a patient based on 6 different areas of cognition. Oftentimes people associate Alzheimer's disease with memory loss. And yes, memory could be the first thing that declines. But believe it or not, our brain does many things at once, including maintaining attention, mathematics or arithmetic, visuospatial ability, what we call executive function or planning, organizing, and sequencing. So the MoCA is a good bedside tool that I like to use. It takes about 5 to 10 minutes to complete. It's available in almost 20 languages. It's all online. Go to mocatest.org and anybody can download a copy. Now I would recommend against residents or families administering the test because like anything, a little knowledge could be dangerous.
Exactly.
So it's just a tool that I personally like to use that's standardized, is well validated, and can help me diagnose what type of dementia, do they have dementia, what type, and how severe is it. So
Is it a test you would give over a period of time in terms of different days, different times of the day to kind of get a better feel?
I wouldn't repeat it that often. I would say most often I would use it every 6 months. The reason being is there is some learning that's associated with the test. So I've had patients come into my office repeating on cycle ball flag tree, because they know that I'll be asking those 3 words now, and they've overlearned those to sort of compensate for their memory problems. That's not what you want in a test. You want a test that's really going to look at different parts of the brain and how they're functioning. But yeah, I would say every 6 months at most I would repeat it. Usually for my patients it would be once every year on average.
I'm just, in terms of the hostility that people have towards going to this type of exam type of thing.
Right.
What is your recommendation, or what do you see as the best way to get mom or dad in to see you?
Yeah, that's a hard question as well. It's very difficult. A lot of the legwork is done before they see me. So it's not by me, but it's the family members and caregivers that work with these people with this illness. And the number one thing I would say is don't try to use the strong approach. Strong approach, especially for people that feel themselves being compromised or losing their faculties, becomes they become very averse to that. So I would use what's called the empathic approach, and that means, Mom or Dad, I love you. I care so much about you, and it really pains me to see you in this state. I worry, and just be honest and frank, I worry about what happens when I leave you alone. Do you mind, coming with me, and I'll help you make the appointment to see your primary doctor to address this? That approach is much more effective in most cases to pretty much anything when you're trying to move somebody towards action, rather than you're going to go, you have to go, and that's the way it is.
That's what Patty does to me.
What is the difference between normal aging memory loss and dementia or Alzheimer's? Because, when I noticed it with my mom initially, when I would go stay, I'd stay 24/7. So they're real good at hiding it initially, but when you're there 24/7, they can't hide it 24/7.
Right.
And, you mention it, I mentioned it to my siblings, and they're like, oh, mom's always been a little dingy. That's nothing new. But
Right.
there was more to it than just the normal forgetfulness.
Right. So normal aging, or as we define it as age-associated memory impairment, it happens. Now look, I wish I could say that people's cognition gets better with age, but in most areas, except one, which is verbal fluency, which is the ability to maintain social functioning and social relatedness, that actually stays the same, if not improves over time. But pretty much all other areas of cognition, so processing speed, visuospatial ability, and memory do decline with age. Now, there's a difference between that and the disease state known as, for example, Alzheimer's. Alzheimer's is a condition where you actually get protein that misfolds and builds up in various parts of your brain. So it is a disease. It is not just part of getting older. We used to use the word called senile, and we don't use that word anymore because it doesn't, I think it's a misnomer, because people don't just become senile, they get a disease. And unfortunately, age is the #1 risk factor for the disease. So the major way to distinguish between normal aging and Alzheimer's is by looking at the pattern and extent of the deficits, right? Normal aging, people would have what's called senior moments. They'll think of that word, or try to think, what is that actor's name? What is that actor's name? And by gone, it's gone. They can't come up with the word, especially when they need it. An hour later, it'll be, oh, I remember, his name was Tom Cruise. So in those cases, that's called age-associated memory impairment. The words will oftentimes be retrieved, but at a later stage, okay? Alzheimer's disease is not like that. Typically, the information is actually never learned properly. We think of it as a memory problem, and in fact, Alzheimer's is a learning problem. People can't learn new information because the areas of the brain that are involved in learning, known as the hippocampus, right here in the temporal lobes of the brain, are compromised. And therefore, people can't learn things like, what's my grandchild's name? Or what did I eat for breakfast this morning? So typically what you'll see is short-term memory loss that doesn't respond to cues or time. People won't remember it if given an amount of time. And that has extended into causing functional problems in their life. Unlike age-associated memory impairment, older adults with Alzheimer's, have problems driving, managing their finances, or even medication. So that's the major distinguish. But I want to just caution people about trying to diagnose themselves. This is something I spent a lot of years of training trying to do. It's important that a medical professional actually confers the diagnosis of dementia.
If only we could all be Betty White.
That's right, yeah. Right.
That's how I want to be 95.
Right.
So I'm going to put you on the Alzheimer's spot here. I mean, there's so much talk and so much conversation about this. I mean, it's an epidemic growing in dramatic proportion. Do you see a cure for this in the next 10, 15 years, given what's going on?
Well, where we're at now is far from a cure. We do have some medications that are FDA approved for early and moderate Alzheimer's disease to help not even slow it, but to improve symptoms at various stages of their illness. It doesn't slow, delay, or stop the progression of the actual disease state, okay? So they leave a lot to be wanted in terms of effective treatments. Generally, the medications currently can give people about 6 to 9 months of sort of going back to where they used to be. Now, in the future, there's a lot of exciting treatments, immunotherapies, various biological treatments to try to reverse or actually stop Alzheimer's disease. We're not there yet. I think I'm very optimistic because we understand so much about the disease state that in our lifetimes, the next 10 to 15 years, there could be a significant breakthrough. A lot of the treatment now is focused on earlier detection and earlier treatment. And we have very good diagnostic tools. I'll say this again, very good diagnostic tools to try to understand and identify patients at risk for Alzheimer's disease. They're actually very good ones. The problem is the treatments are lagging. So until we get effective treatments, really the question medically is what's the point of diagnosing earlier? It causes a lot of hysteria and anxiety, but that's more of an ethical question. I think though, Ron, in 10 to 15 years, we will have some good treatments available for earlier detection and treatment.
Fabulous. Well, that's good for, hopefully, good for. Dr. Samari, we thank you so much for coming today. It's been a wealth of information. I hope people will reach out to you. Again, it's the 60-year-old child who what to do about mom or dad that we hear about all the time. And I think your advice and your expertise will really help the family cope with this dreaded disease of Alzheimer's and dementia. So thank you for joining us today.
You're very welcome.
And we'll be right back with more Senior Stay or Go TV.
When you belong to a community, it makes you feel safe. It inspires you to thrive. It honors your achievements, and it makes you feel at home. For nearly 20 years, Belmont Village Senior Living has created communities that have enriched the lives of seniors and their families, providing places where seniors lead healthy, purposeful lives under the care of staff who truly understand their needs. Belmont Village offers assisted living, independent living, and memory care in a continuum that supports residents when care needs change and providing for couples of varying care needs.
It's nice that we can be together. She needs a little bit more care than I do, and I don't have to do any cooking or shopping.
Aging is a gift. We invite you to embrace it with us and be a part of our community and our family. Belmont Village Senior Living, the community built for life.